Thank you for joining us for this special series of This is Getting Old, sponsored by the 2020 George Washington University's University Seminar Series. Towards Age Friendly is brought to you by Melissa B., PhD, in collaboration with GW Center for Aging, Health, and Humanities. Welcome to This is Getting Old. I'm your host, Melissa Batchelor, and today we're going to be talking about rethinking nursing home care and care of older adults. And I'm joined by Dr. Stuart Butler from the Brookings Institute. So welcome, Stuart.
Thank you. Pleasure to be here.
Great. So maybe before we get started, you can just introduce yourself and we'll go from there. Maybe tell us a little bit about Brookings also.
Sure. Yeah, I'm a senior fellow at Brookings, which is one of the largest think tanks in the country. And we focus generally on public policy issues. And my focus is really generally the area of healthcare, but more particularly the challenge of getting different sectors to work together to achieve better health, sort of like housing, transportation, the health system, and so on. And I've been doing that in a variety of ways of looking at different populations and so on. But when you start thinking about older adults, it's so important to think about how various supports need to come into place for people to have a successful, healthy, sort of aging experience, as it were. And that's really what led me to concentrate a lot on these issues associated with nursing homes and alternatives to nursing homes and all the various aspects of what does it take to age successfully and happily and to thrive in that. And that's when you start to look at those things, you begin to see a lot of problems with the existing arrangements that we have, and also a lot of possibilities.
Yeah, I was going to say some of the things that you mentioned, housing, transportation, all those things are also very, the pillars of kind of age-friendly living.
Mm-hmm.
So I know one of the recent things that you've done, you have assembled a group together to talk about kind of rethinking, long-term care and how to care for older adults, and publish your findings in this convergence report that was released towards the end of last year. So maybe tell us a little bit about how this report came to be.
Sure. Well, first of all, the organization Convergence actually focuses on a whole range of different issues, and they try to bring together people from very different backgrounds and different points of view to see, first of all, if there are areas of common ground or ideas that people really agree on, and then to kind of work forward to say, well, okay, if that's the case, are there policy changes that could be put into place that a consensus of people could agree on to reach a better future and a better outcome? So basically, the Convergence was asked by the Hartford Foundation, which funds a lot of work in the long-term care area and aging, to just really bring together, I think it was about 50 people, and really get them to brainstorm on this issue, brainstorm about nursing homes and what's going on there and what could be done differently, brainstorm about other ways that people can age outside of nursing homes. And that was a very important part of the conversation. A lot of things are happening in that area. And then really thirdly, looking at both the workforce in the caregiving field, the nature of the workforce and how to think about it differently in the future, and basically the financing as well of aging in America and care and nursing homes and so on. And we got them all in the room together, or three separate meetings, and really just got everybody to talk and so on. And we found some very interesting areas of agreement. Not everybody agreed, but opportunities to really look at, such as, just reimagining what is a nursing home, what's it for, who is it for, and why are people there? And then also, are there ways of enabling people to live more successfully in their own homes and their own communities? And that's not just a question of thinking about their medical care or safety in the home. It's also things like what we call social capital. What's going on in the community? How can there be a broad group of people and institutions that help people to stay in their own home and to avoid isolation, to be safer, and so on. And then there was a lot of very interesting conversation about the workforce. The workforce today, as you and I'm sure many of your viewers know, I mean, is predominantly low paid, very heavily immigrant, people often working 2 or 3 different jobs. It's a low skilled, low cost workforce. And it's not obvious that that's the right way to have this workforce. So there was a lot of conversation about really fundamentally rethinking the way in which the caregiving workforce operates, the skill sets, how you pay for it, and so on. So those were the main areas that we really looked at. And there's plenty of meat in each of those areas. And I think an opportunity to think really constructively about how to change things in the future so that all these pieces can actually work together more effectively. You know, institutions often, you get to a point where you say, you know, things have changed, and the way this institution has been operating for many years is maybe not the way it should be operating in the future. And that goes everything from looking at libraries in our community, which are now very different than they were, you know, 20 or 30 years ago. They are information centers for a whole range of things. Think about our tendency in the past to always send the police in when there was a mental health crisis taking place. And now we're beginning to think, are the police the right institution to be the first responders for mental health issues? And there's a lot of rethinking in that area too. So I think, you know, we are on the cusp of possibly thinking quite differently about nursing homes in the future.
Right. And I think one of the points that you're bringing up is, you know, the system of nursing home care, and, you know, long-term care is a wide range of services, from, you know, skilled nursing facilities to assisted living to home and community-based services. So when we say long-term care, it's kind of those are kind of the sectors, but the, right, you know, the nursing home system, you know, like you said, is very much out of date. And a lot of that has to do with the payment model, you know, for that product. So what were some of the ideas that people came up with for kind of rethinking nursing homes and kind of the financing piece of it?
Well, you're right. In terms of looking specifically at nursing homes, they do really cater to 2 broad types of population. One are people who have been released from hospital and need a lot of care for, you know, some weeks, sometimes months, before they're able to be independent again. And then you've got others for whom a nursing home really is their sort of their final accommodation, if you like, either because they have frailties, either physical or mental frailties. That means they really can't live by themselves, or it's perceived they can't live by themselves. And of course, we have the issue in this country that people run out of money when they try to care for themselves or to care for their aged parents in their own home. They may be possible, but it's expensive. And often people run out of their savings, and then they discover that they have to go onto Medicaid for people who really have exhausted those funds. And it turns out that Medicaid will pay reasonably generously for care in a nursing home, but they won't pay for that care in a lot of other settings, and particularly and extensively within a home. So they're really forced by the payment system to go into a care setting, which may not be the right one for them, mm-hmm. and may not be ideal, and certainly may not make them happy, and may cut them off from their family. But it's the only one that's paid for. So looking at the payment system is really important. We have a payment system that I feel is very out of date in terms of how we think about successful aging.
Yeah, I know, like, even as a clinician, you know, I work full time, you know, families would say, well, so what's the next thing? Like, what's the next best thing for mom? And the first response was, well, let's talk about your finances, mm-hmm. you know, because it depends on what your personal financial situation looks like. And then we have to try to plug you in to what, you know, these other payment models look like. And a lot of people don't understand that aspect of it. So, and actually was having a conversation with my family this past weekend where we were talking about, you know, Medicare and Medicaid.
Right.
and understanding the difference and what you were talking about with the short stay resident. So if you fall, break a hip, and need short-term rehabilitation, that's one segment. And Medicare does cover that aspect of a skilled nursing home stay, but Medicare doesn't cover assisted living, and often doesn't cover the home and community-based services aspect
Right.
of it. And then after you spend your personal, like if you need long-term care, but you don't have a kind of qualifying event, then it depends on your personal assets. And then once you've spent down, then you qualify for Medicaid. And half of most state budgets is long-term care.
That's right.
But then when you put it into perspective, only 5% of people over 65 really ever end up in a nursing home, but they account for 50% of the state's budget. And so what were some suggestions about how to change the financing model or workforce elements?
Yes, well, you're right. Of course, a lot of people get a really unpleasant surprise when they think that Medicare covers long-term care and services of that kind. And there's many people who just are hit by that shock and not realize that that's possible. I think another dimension to this, which we didn't dwell on a lot in these conversations, but certainly others are, is the really the collapse of the long-term care insurance industry. Because you're right, there are a lot of, the probability of spending a long time in a nursing home at great expense is low, but when it happens to you, it's devastating financially. And of course, in a way, that's a perfect opportunity for insurance. That's why we normally use insurance. We don't use it for kind of first dollar coverage. We use it for those unexpected heavy amounts. But the industry has really declined very sharply in the last several years, in part because younger people don't think of long-term care insurance. They think of life insurance and homeowners insurance and car insurance and things like that. But they don't tend to think about long-term care insurance. In fact, there's a lot of surveys to suggest that people think it's kind of icky, that they don't want to think about it. And then the other thing is that, of course, we've had a situation where people are living longer, and they're often living longer with, diseases or decline in their mental faculties, and they can't, live independently. In the old days, if you look at the patterns of aging, people tended to live, into their 60s or 70s, and then something really bad would happen to them. They'd get a terrible disease, or they'd have an accident or something like this, and they would die. I mean, that is what happened. It was like a cliff. Now, of course, as we both know, that's a long, long tail to that aging process now. People live longer, and they live longer with sometimes very expensive illnesses, and they can't be independent. And so insurers face these enormous potential costs too. So they've tended to pull back. There are far fewer companies in this area, and it's more costly because fewer people are taking it out at an earlier age. So one of the partial solutions for really what you might call the middle class, people who do have some savings but are afraid of them being exhausted and then ending up on Medicaid, is actually to provide a so-called catastrophic backup to long-term care insurance, a public program that would limit the financial exposure of insurance companies. And one of the ideas is to have legislation that would set this up in order to stabilize the long-term care insurance industry, to make it more viable in the future. If you did that, then far fewer people would fall into this trap of being unable to pay, wiping out all their insurance and the inheritance they're going to give to their kids, and going to a nursing home because Medicaid is the only financing option for them then, and that's all it pays for. So dealing with the insurance area is an important component of fixing this whole problem of how the payments are done. But the key one, I think, is to look at changing the rules in both Medicare and Medicaid as to what they would cover. And a lot of us feel that if that was the case, and Medicare and or Medicaid covered alternative services, were more open to covering home-based services and services of that nature, it would actually save government spending, public spending on Medicaid and Medicare, actually, in the long term. So there's a lot of interest in revamping the rules and the regulations associated with particularly Medicare and also Medicaid.
Mm-hmm. Yeah, and as you talk about that, I think the number one strategy that people should keep in mind is, how do you prevent frailty? How do you age well and continue to be able to take care of yourself, rather than thinking it's inevitable that you're going to experience all of this decline and end up in the skilled nursing home? Because as I just said, 95% of people do stay in their own home. So if we think through kind of the 95% that aren't going to need skilled nursing home, what are some of the developments or ideas that people had to help people age in place and in their community and have their families help?
Well, there's a lot of things that we discussed, a lot of ideas. It's a very exciting area of ideas, actually, because you have architects involved in this conversation about how do you actually design housing that is safer and more open, and including things like looking at group housing in various forms, and thinking about ways in which sort of multifamily units can be designed in such a way that an older person can have their privacy and so on, but can actually have some social interaction in, say, one unit, which becomes, the kitchen and almost like a family room and so on. So things like that are really important. There are also other design features that are important. Thinking about also, how do you build what you might call social capital, so that a person maybe in their own home, there are many people who are in their own home, but are really isolated. They're cut off. They don't have connections. So looking at ways of building these relationships, there's a system actually in this country, pretty widespread, very much in the Washington, D.C. area, in the Midwest and in the West, that it's called social villages or senior villages. And this is really a mix of volunteers and usually a paid executive director. And they provide a whole system of supports for people who are living alone. And that's everything from taking them out to go shopping, to maybe accompanying them to a medical appointment and actually taking notes for them, so that they don't forget what they're supposed to do, and there's somebody younger there to help them. Going through the home and literally making it safer. Doing a lot of things, in other words, to connect the person socially, but also to deal with some of the things that can go wrong in a home if it's not set up for somebody who is older. There's a lot of improvements in technology as well, of monitoring people, so that a doctor or a nurse in the area can know if that person is getting unsafe in some way, a potential fall, having a potential fall and so on, and connect with them and so on. So there's a whole lot of things going on in addition to improving services, medical services at the home, that actually are making being at home a less isolating experience and a safer experience for people.
Yeah, and we did a podcast on age-friendly housing, and Ryan Frederick was on that.
Right. He was at one of the meetings.
Yeah, and then this village to village movement. I'd actually never even heard of. I've been in long-term care for 25 years and moved to DC, and they were talking about the villages. I'm like, what are the villages?
Yes.
And so it is a really interesting model, and DC has a lot of them. So if you haven't heard of the villages, that's an initiative that any community can create. And you and I talked earlier that I do think that it's not going to be so much Medicare and Medicaid and the health system that's going to figure this out, to help us. It's going to be this social capital that you're talking about. How, who are the volunteers, and even intergenerational volunteers, and then what are the things that people need in that area, and then communities coming together to create solutions. So this isn't, just the geriatricians of the world or the geriatric nurses and social workers. It's going to take everybody pulling together. And I think one of the ideas that you mentioned, kind of home safety, I always think of Sarah Zanton's program and the Capable program. Where they'll put a social worker with a handyman and usually like OT, PT, or some type of therapy department to do a home safety evaluation. And it's amazing how, just like you said, some little tweaks can help someone, to age in place.
And that program, Capable, as you know, has been very carefully evaluated. And, it's been shown for every dollar spent, it's shown to save about $7 in Medicare costs. And this is, because of things like avoiding falls. You have a fall and a broken hip and go into the hospital. And so this is hundreds of thousands of dollars for Medicare. If you can stop a few of those happening, that's an enormous saving. And so this has been calculated and so on. And yes, and I mean, the interesting thing about Capable is the OT, the occupational therapist, actually develops a plan with the individual, with the person, as to what does it take for them to be successful and realize their goals of what they want to do and what's in the way and what's a danger. And then the handyman comes in and looks at the lighting or the bathroom and so forth, and deals with those issues. The nurse looks at other things, and they look at connecting the person with social services in their area, maybe with the senior village, and so on. So it's a way of going in and doing an assessment and building a plan, and then kind of working together to make that happen. That has an enormous impact for a relatively small investment, because it deals with things that can easily go wrong. It puts the person at the center, saying, well, what do you want? What kind of life do you want? Mm-hmm. And by then designing around that, it can really improve outcomes, and including mental outcomes, of course, social outcomes. And this is really important. And the institutions within the community that can play a role in this can be really important. I mean, you can connect older people with the schools, for example. You mentioned 2 generations and so on. And I know cases of older people doing storytelling in schools about what was it like, back in those days. And then in return, younger people coming and visiting and so on. I mean, connecting the generations in ways that we know is so important. I mean, these are the kinds of things that are really important. And there's lots of examples around the country and around the world, actually, of really efforts to do this in some pretty creative ways and some important ways.
Yeah. And as you were talking, it made me think of, an age-friendly public health system,
yes,
who could kind of engage, age-friendly state or cities and communities to, to then engage with, civic leaders to kind of do sidewalk assessments, like to look at the built environment and make sure that things are safe, to have maybe a public health initiative where they partner with the area agencies on aging, where they can kind of replicate the Capable program, but then also connect people to the resources that the area agencies on aging have. I think a lot of this is just people aren't aware of what's even out there. And I was actually reading an article last week, I haven't finished it, but it was talking about kind of this intersection of structural ageism and racism, and you think about all the different ways we've set people to age in a very we've set people up to age in an isolated way, mm-hmm. versus, if you set people up to say, join a village, here and to encourage businesses to think about how, they can contribute.
That's exactly right. Yeah.
So if we're talking, go ahead.
No, I was going to say, I think that's really important. I mean, to think about how to connect these things, the dots together in a way, as you said. That's often a huge problem, as we both know. I mean, you can have different services available, including volunteer services. And if people don't know about it, and if they don't actually look at ways to connect those together, as I said at the beginning, part of what I try to do at Brookings is to look at what are the barriers to collaboration across sectors, to these different sectors working together. And often they're very simple things. Often there's just no overarching organization to get these different agencies in the same room. You can fix that. I mean, you know, the DC, for example, you know, has a department of aging that is designed to help the different service different groups within the DC government and within the private sector to literally get to know each other and to start to plan together. That's a simple but often absent feature that's really important. So looking at just simply how to get these things connected can really solve a lot of the problems. Once you start to get them connected, you then start seeing that things like payment systems don't fit what you're trying to do. You know, they'll pay for one thing over here, but they won't pay for that over there, and both are necessary. And if instead of paying, you know, so much for healthcare here, we put a little bit of it into building out the social services or the housing that people need, you'd actually be gaining for the whole city or the whole state. I think this is becoming better understood now. There's a lot more investigation at all levels of government about how to connect these different departments together. What's in the way? How do we train people? How do we make it okay for you in one agency to spend money that actually benefits another? What the objective of another agency is, because we're all trying to help the people who are our residents. And so breaking down some of those boundaries between how money is spent or how data is shared is another issue. People just literally don't know who's on the books of a social service agency, who's getting medical care. If you don't know all this, it's really hard to do a plan together. So it's these pretty basic, almost like common sense things that seem to be really important to enable people to live successfully in their own home more than they do today, with a lower probability of something happening to them, or them running out of money, or them just becoming so isolated they want to go into some facilities because they want to talk to people.
Yeah, I mean, there were a lot of people that would come into the nursing home and they'd been there a month, and the family's like, you know, they blossom. Like, we haven't seen them do this well in years. And it's like, well, that's because they're finally not at home by themselves, which is bad for your brain. It's bad for your overall health. There are people here for them to interact with. And, you know, the ones that were really insistent of going back home tended to not do so well because nothing changed, you know, around the social aspect of life. And I think a lot of what you talked about really is, how do we build this ecosystem of all of these different multi-sector partners, and what are the common data elements so that we could share data and know kind of what the needs, what all the needs are, and not work so much in silos.
Yes.
And I think that's one of the biggest challenges. So then we'll talk about, let's move into kind of the third segment here, talking about the caregiving workforce, because people need care. We need people that can provide the care.
Absolutely. And as we know, and I mean, and COVID underscored, I think, people's understanding a little bit more about the workforce, in that, as I said earlier, it's a workforce that tends to be very low paid, really generally poorly trained at the nurses, at the aide level at least. There are other, of course, well-trained people in a lot of nursing homes, skilled nurses, but in a lot of cases, we're talking about people with very, you know, low skill, low training levels, really licensing, which is questionable, often licensing that gets in the way because sometimes very basic tasks that somebody could be doing, they're literally not allowed to because of the licensing, like, you know, to some extent managing medications for people, doing other things and so on. So it really is a mess, to be quite frank, the workforce, the way in which we operate the workforce. So there were a lot of thinking about how to think differently about this workforce. And I'm reminded in this about, if you go back, you know, 50 or 60 years or so in this country and most other countries, and you think about nurses, you know, nurses decades ago was a relatively unskilled profession. I mean, they looked after people in hospital and sometimes at home. but they didn't have much training. They didn't get training in the medical area very much, and so on. And now think of that profession today. It's a very broad, multifaceted profession. Some nurse practitioners they are the equivalent of doctors for most people, in emergency care centers and this kind of thing. There's a wide range, and there's a career path, and so there's none of that in much of the caregiving workforce. So a lot of what we're looking at is, first of all, improving the training for people. At the moment, there's very limited federal training and federal requirements on states. That needs to be expanded enormously to really raise the skill level. Secondly, it's really important to think about even lower skilled aides as that they should be part of a team of people and be a conscious team. We know in lots of areas of business and services that if you think of a group of people as a team, even the people with fewer skills can play an enormous benefit, provide enormous benefit and value added to the whole team. And we know, you and I know that when you start looking at people who are drivers, for example, who drive older people to their appointments and so on, they get to know about things about that person. Some of the lower paid people who come in and just bathe an older person at home, they talk and they get to know a lot of things about that person that their doctor doesn't know because it isn't the same kind of relationship. And so seeing even lower skilled people as part of a conscious team and doing it that way and organizing that way could significantly enhance the value of lower skilled people, and hence their financial benefit. And if their financial value is increased, you can pay them more. That's a really important kind of economist view of this. If people are part of a team, and because they're part of a team, they're actually adding enormous value to others in the team because of their knowledge of the person and so on. That has a financial value and can be shared with the person. So that's really important. And then I think also seeing the workforce really as a career and consciously doing so and sharing tasks. One of the things about teams and people see that as a career is sharing the tasks is something that you see in other fields, less so in this area. But there are some assisted living and even some small facilities like greenhouses, so-called greenhouses is an example, where they've broken down the sort of like the professional boundaries about who does what. So a highly skilled person may do some pretty mundane things. And it turns out that mixing those tasks and operating as a team in this way, everybody on the team, including the highly skilled person, gets much more satisfaction from that job. That's one of the things they've found in these surveys. So thinking about the workforce in these different ways is really important. And the net result would be a very different looking workforce in the future in terms of what people did, how satisfied they are, the turnover rates. They have very high turnover rates in particularly aides in nursing homes, because they're working 2 or 3 jobs. They're having, they fall in and out of the workforce. They don't have a lot of skills and so on. So I think we can do an enormous amount in that area. It's a very exciting opportunity.
Right. And I think, the turnover rate's 100% easy, in nursing homes. And I think a lot of it speaks to the fact that they are giving basic training. You have to have a certain set of skills in order to become certified as a certified nursing assistant. But that training often doesn't include how to care for someone with a cognitive impairment.
Right.
I know there's nothing in most state nursing assistant curriculum about how to feed an older adult with Alzheimer's disease, and so how do we build this dementia capable workforce, but also people that just understand normal aging compared to abnormal aging, and that content is not given at the CNA level. So I think that you do this certification program, you think that you're ready to go into the workforce, and then you see the people you're actually dealing with, and you're like, I don't have the skill set to deal with this, so people just leave. Yeah, and they're like, it's easier to work at McDonald's and I get paid more money. But again, and I think that when we talk about federal initiatives, right now, the only kind of federal initiative we have for training the long-term care workforce are the GWEPs, the geriatric workforce education programs, but they often don't trickle. Some of them don't actually deal with like the aid level, or kind of the, how do we build leadership capacity for nurses, in long-term care.
Right.
So I just think that there's it's the pay issue. It's just a very complex, workforce issue.
Yes, and the federal government has a role in setting the broad standards and the design. There are several people in our group that are very versed in that area and have a lot of ideas to do that. And then the state, of course, which carries out much of it, or requires the carrying out of much of the training. And I think, to get back to what I said about the team and the value of people working in a team, I think one of the kind of dilemmas, if you like, we have now is, I think, a lot of nursing homes, a lot of people in this field think, well, there's no point in investing a lot in more training than is necessary, because this person is going to leave anyway. There's going to be a turnover. But it's a chicken and egg problem, It's
right.
By not investing in this way, yes, you get turnover. If you did invest in that way, we've certainly seen studies to suggest that you'd see a much higher retention rate, and then people would become, of course, much more experienced. That means they could then carry out more, higher level tasks, and so on. So you've got to make the commitment up front on the training and adequate pay. And that, I think, is going to pay off in retained people and people who you can trust to do multiple services. And that changes the whole picture.
Yeah. Well, and I think the point you're making to me is, one nurse, if you've seen one nursing home, you've seen one nursing home.
Yes.
Because there are high performing nursing homes that I've been into where the staff have all been there like 5-10 years, all of them.
Yes.
And then you can go to a low performing nursing home that doesn't kind of invest in this training or build, a team and a home-like environment for the staff and the residents, and that they do have turnover all the time.
That's correct.
But I think that, just like different states have different criteria for how to even meet your certification requirements, each facility and each corporation, whether they're for-profit or not for-profit, all of those factors go into that also.
Absolutely. And it means that we've got to, I think, when we look at the regulation of nursing homes and we look at the payments to nursing homes, we've got to encourage a variety of types of nursing home, and in many cases specializations in the nursing home area, much more than we do today. There certainly are a variety of nursing homes and assisted living, and it's a continuum, really, I suppose. But it's important to make the funding flexible and to do pilots. to explore different structures, different ways. You can have, in principle, kind of nursing homes that are partners to, say, large public housing authorities, or actually even private developments in different parts of the country. And so the nursing home, it is a nursing home, but it's not it doesn't always have to be some separate building that people go off to, and that they go in the door and they just stay. It can be connected in some way. There's a lot of interest in so-called, not just senior villages, but so-called healthy villages, where you look at different institutions within the community, and they do outreach and they partner in a variety of ways with people in the community. Some will be in the nursing home itself, but the nursing home may be providing skills and services and maybe technical assistance to other institutions, maybe a senior village in the community, and it's a partnership. Well, often rules, regulations, payment systems just get in the way of doing this right now. So by being more flexible, I think we will see in the future a very different kind of arrangement, more what I would call a hub and spoke arrangement, where you get certain institutions that do carry out their traditional function, but then they're also providing their services in some way to others in the community, and sometimes in partnership with intermediary organizations. That's, I think, the future of much of aging in this country. Now, as we know, I mean, people will often get to the stage where either physically or mentally they can't even, they can't be alone or in a community, in a normal community. So they have to go into nursing home. But in the future, that's probably going to be a much smaller group of people if we do these things than we think it will have to be today. And that's exciting. I mean, I think it means a much more satisfying aging, and people thriving as they age, rather than thinking it's just a long process of deterioration,
Right.
And just sadness.
Right. And so I think from my perspective, the Convergence report gives a lot of hope and optimism. You ask kind of the three broad questions, and with each of the areas that we've talked about, there are actionable items or ideas to think about. And so we'll definitely include a link to the full report on my website. So any other final thoughts about rethinking long-term care?
Well, I think, as I maybe said at the very beginning, that you get institutions and they operate in a certain way, and then at some point you begin to think maybe this isn't the way it should operate, and sometimes it can be a little chaotic for a while, but sometimes the end result is a very different looking institution, and I think we've seen that in a number of ways, and I think nursing homes are very important components, of course, in our aging process, and very necessary for a lot of people. But we've had a situation now where, for years, the sort of the theory has been, people get older, and at a certain point, they run out of money or they can't live alone, and so then they have to go to a nursing home. And that's not the case. There's a whole continuum of possible arrangements. What we have to do now is, through looking at rules, changing payment systems, thinking outside the box, thinking differently about the workforce and what's possible, to open up those possibilities in ways that haven't been done. If we do that, I think we'll see a very, very different process of aging in the future for a very large number of Americans.
Right. And I do think, the creativity and the, asking questions or questioning the system, it comes from people that are actually experiencing that. So, hopefully anybody that's listening to this or watching it on YouTube, they can drop a comment below, because that's another way to kind of hear different voices and hear different questions. So I thank you very much for being with us today. And I'm optimistic that we're going to get there, and, things will be better 10 years from now. Hopefully sooner than that.
Yes, I hope so. Thank you.
Just getting people to the table.
Appreciate the opportunity. Thank you.
Yeah. All right. Thank you so much. Thank you for joining us for this special series of This is Getting Old, sponsored by the 2020 George Washington University's University Seminar Series. Towards Age Friendly is brought to you by Melissa B., PhD, in collaboration with GW Center for Aging, Health and Humanities.
Thank you for joining me for this week's episode of This is Getting Old, Moving Towards an Age-Friendly World. You can find more episodes like this on my YouTube channel, Melissa B. PhD, and don't forget to subscribe. You can also visit my website, melissabphd.com, and check out the podcast and blog section, because that's where I put all the hyperlinks and different things that we may talk about in any given episode. You can follow me on social media, Twitter, LinkedIn, Instagram, and Facebook. And you can also find the audio version of the podcast on iTunes, Stitcher, Spotify, and Amazon Music. So I hope this podcast gives you ideas of different things that we can do to move towards an age-friendly world, because when the world is age-friendly, it's friendly for everyone.